Next to Dr. Ramesh Venkatesh. He's got a simultaneous presentation in another hall. Then next.
Shall I start?
Yes, please. Please start.
Yeah, good morning everyone. The topic for my free paper presentation today is Contributory Factors for Developing Foveal Neovascularization in Proliferative Diabetic Retinopathy. I'm Dr. Ramesh Venkatesh and I have no financial interest. The hallmark for diagnosis of PDR is the identification of an NVE or NVD or both. Now, foveal NVE in PDR cases is a very rare finding, and the reason why the fovea is usually spared is because it's a neurovascular structure. It does not have any retinal capillaries and is primarily supplied by the choriocapillaries. In proliferative diabetic retinopathy, the choroidal flow and the volume reduces, the choroidal perfusion reduces, and therefore it becomes a theoretical possibility for a new vessel formation to occur at the fovea. There is existing literature which talks about foveal neovascularization in proliferative diabetic retinopathy, but what this literature lacks is that there is no information which talks about the contributory factors to the development of foveal NV. And hence we decided to plan this study, where the aim of the study was to analyze a series of cases of foveal neovascularization in proliferative diabetic retinopathy and ascertain the factors which lead to its development. Coming to the methodology, it's a retrospective case control study where the cases are patients with PDR with foveal neovascularization and no diabetic maculopathy, and control cases of PDR with no foveal NV and no diabetic maculopathy studied between Jan 2020 and December 2020. So basically we diagnosed PDR on the basis of angiography and then looked at the presence of neovascularization within 1 millimeter ETDRS circle at the fovea. If they were present, then we included them as cases, and if they were absent, we included them as controls, and then did the OCT and OCT angiography in these patients. Coming to the OCT measurements, we looked at the OCT measurements were done on the Heidelberg Spectralis machine, where we looked at the total retinal thickness, the inner retinal layer thickness, the outer retinal layer thicknesses, the RP layer thickness, and the subfoveal choroidal thickness, all of which were obtained by the automated tool available on the Spectralis software. The OCT angiography was done on the Avanti OptoView machine, where you measured the FAZ area on the 3 millimeter and the 6 millimeter scans, the vessel density in the superficial capillary plexus and in the deep capillary plexus at the 1 millimeter grid, and the total 3 millimeter and the 6 millimeter areas. Coming to the results, so we had a total of 124 eyes diagnosed angiographically with proliferative diabetic retinopathy and 12 eyes of 10 patients with foveal neovascularization, and a similar number of cases were taken as the controls. The prevalence of foveal NV in our study was around 10%, and coming to the comparison between the cases and the controls, most of them were comparable except for the presence of type 2 macular telangiectasia, which was associated with foveal neovascularization in PDR cases. So type 2 MACTEL was seen in eyes with PDR and foveal neovascularization. Coming to the OCT findings, the retinal thickness between the cases and the controls were all comparable, but what was important and interesting was the thinner choroid which we had in the cases group compared to the controls group. Even when you look at the OCT angiography findings, we found that the foveal avascular area had enlarged in the 3 millimeter and the 6 millimeter scan, both in the superficial and the deep capillary plexus slabs, and the vessel density had increased, the vessel density had reduced, in the case group. So in eyes with foveal NV, we can say that the choroid was thinner at the fovea, the FAZ area had enlarged, and the vessel density at the fovea was reduced. Now coming to the univariate and the multivariate logistic regression analysis, we identified that it is the foveal avascular zone in the 3 millimeter by 3 millimeter superficial capillary plexus slab which contributes primarily to the development of the foveal neovascularization. So increase in the FAZ area in the 3 millimeter by 3 millimeter scab, primarily in the superficial capillary plexus, it leads to the development of foveal NV in PDR eyes. The strengths of our study were the largest series of cases of foveal neovascularization in PDR cases to be reported in literature. We had a control group. We analyzed for the different OCT and OCT angiography parameters, and this study also explains the possible etiopathogenesis for the development of foveal neovascularization in PDR eyes. But there are some limitations as well, and the limitations being the small number of cases. But to get a higher number of cases, we needed to screen more cases of proliferative diabetic retinopathy. We did not have follow-up data to look into what happened to the foveal neovascularization, We could not comment on the prognostic differences between the two groups, whether these foveal neovascularizations eventually bled and led to a premacular bleed, and we did not look into the treatment outcomes with anti-VEGF, PRP, or both. So to conclude, foveal neovascularization in PDR is an uncommon finding with a prevalence of 10%, and when it occurs, there is reduced perfusion of the choroid and the inner retinal layers. Thank you very much.
Thank you, Ramesh. Nice paper. Couple of questions. Now, when you say you excluded MACTEL, so what are the diagnostic criteria of exclusion of MACTEL, and how do you identify with foveal NV?
So we did not exclude MACTEL. We in fact found MACTEL in 5 patients of PDR cases having foveal NV. So we did not exclude MACTEL. The confusion was whether we have foveal neovascularization or epiretinal neovascularization, which is being described in MACTEL eyes as well. So now you are confused whether this foveal neovascularization is secondary to MACTEL, or is it because of the PDR disease itself? So the OCT tells us the answer, in the sense that the choroid, when it is thin, and the inner retina when it is affected, and you have a larger FAZ area on the octa, it tells that that is what is primarily leading to the foveal neovascularization, and therefore the MACTEL was not responsible for the development of the neovascularization.
Cases, how many neovascular fronts were nasal and how many were temporal?
So most of them we found it on the temporal aspect of the temporal margin of the FAZ itself. Yeah, but we had 2 cases where we had it on the nasal aspect as well.
They were not extensions of the NV?
They were not extensions. They were totally independent.
Any difference in choroidal thickness in patient who had MACTEL versus foveal NV?
In patients who had MACTEL versus foveal NV in PDR cases.
Yeah.
So the choroidal thickness in the MACTEL group was not affected.
Not affected.
Not affected.
And nor did they have, they may not have had clear-cut features of MACTEL, but abnormalities in the middle retinal layers or like
Yeah, so when we look at the staging of MACTEL itself, sir, you develop the neovascularization only when the pigment plaques and the stage 4 disease develops.
No, I'm talking about your
PDR.
foveal,
Yeah, so we did not have any of those features. We did not have any of those features, yes.
because with thinning, as you're mentioning, so there was only choroidal thinning, no retinal thinning.
No retinal. Yeah, but the FAZ area on the octa and the inner retinal areas, means the vessel densities, they were affected on the OCT angiography.
The management approach changed when you are treating these
Yes,
cases,
yes,
though you
yes.
have not probably evaluated.
We have not evaluated, but when it comes to the clinic, the minute we have a foveal neovascularization, we usually tend to go more towards an anti-VEGF, combining it with an anti-VEGF therapy, rather than when you have no foveal neovascularization, we treat them with pan-retinal photocoagulation. Yeah, thank you very much.